Welcome back to another video. In this one, we have a medical case of an 83-year-old man who was admitted to the hospital with right hip pain. Now, this patient had a past medical history of type 2 diabetes, hypertension, high cholesterol, chronic kidney disease, gout, and prostate cancer. Previously undergone a right total hip replacement following a road traffic accident. Little did he know that his stay at the hospital would take a dramatic turn. During a planned revision of his hip prosthesis, doctors discovered a copious amount of pus, indicating a prosthetic joint infection. The culprit, well, it's a common bacteria known as MSSA, or methicillin-sensitive Staphylococcus aureus. The patient was promptly started on high-dose antibiotic named flucloxacillin, but he was also given regular acetaminophen or Tylenol for pain relief. However, his post-operative course was far from smooth as he developed sepsis shortly after the surgery. Fast forward 1 month, he's still in the hospital, and the patient's condition took a perplexing turn at that point. The ICU team was urgently called to take a look at him after he experienced sudden deterioration in his level of consciousness. Upon examination, he was more or less comatose. He had a GCS or Glasgow Coma score of 3 out of a possible 15, indicating a severe impairment in brain function. Heck, even a dead person will score a 3 on that GCS score because that's the minimum score possible. As far as his vital signs were concerned, his respiratory rate was elevated at 25 breaths per minute, but his blood pressure and his heart rate were in the normal range, so those were stable. The puzzle deepened even further when the arterial blood gas, or ABG, revealed a profound metabolic acidosis with a pH of 7.1 and a serum bicarbonate level of just 5.6. Anion-gap, which is a measure of the difference between the positive and negative ions in the blood, was a staggering 41. And that's after correcting for low albumin levels. The medical team, they quickly ruled out common causes of high anion-gap metabolic acidosis, meaning common causes of HAGMA. For example, lactic acidosis, his lactate was normal. The patient did not have diabetic ketoacidosis. The patient didn't have any alcohol ingestion. In fact, the mnemonic that I like to use for figuring out what's causing the HAGMA is my modified version of MUDPILES, which is methanol, uremia, diabetic ketoacidosis, as well as the other ketoacidosis like alcohol ketoacidosis and starvation ketoacidosis. The P is propylene glycol plus propofol. The I is for isoniazid. Also I is for iron. The L is for lactic acidosis, and many different things can give you a lactic acidosis. The E is for ethanol and ethylene glycol. And the S is for salicylates such as aspirin. So at this point, you're probably wondering what could possibly be causing his high anion-gap metabolic acidosis. What is causing his medical condition? Why is he comatose? Well, I would like to introduce to you, if you don't have already, a third P in this MUDPILES mnemonic. And that third P is called pyroglutamic acidosis, also known as 5-oxyproline. So pyroglutamic acidosis is a rare cause of high anion-gap metabolic acidosis that results from a disruption in the body's glutathione production and pyroglutamate metabolism. Glutathione is a crucial antioxidant that helps protect our cells from damage, and its production involves a complex cycle known as the gamma-glutamyl cycle. In this cycle, the amino acid glutamate is converted into pyroglutamate. Here's where the chronic use of acetaminophen comes into play. Acetaminophen, when taken in either large doses or for extended periods of time, you could be on a regular dose. Typically, we limit the maximum amount of acetaminophen in a day to 3 grams per day. So even if you're on or below that recommended 3 grams per day, if you're taking it for an extended period of time, it is still possible to develop pyroglutamic acidosis. The reason being because over time, it can eventually deplete the body's glutathione stores. Now, this depletion triggers a negative feedback loop that leads to the accumulation of pyroglutamate, also known as 5-oxyproline. To make matters worse, the patient was also receiving high-dose flucloxacillin. That's an antibiotic that directly inhibits the activity of 5-oxyprolinase, further impairing the breakdown of pyroglutamate. The combination of glutathione depletion, coupled with impaired pyroglutamate metabolism and reduced renal clearance due to the patient's chronic kidney disease, created this perfect storm for pyroglutamic acidosis to develop. This relatively uncommon condition is often underdiagnosed or missed because the diagnostic tests are not widely available, and the results can take several days to come back. But the classic story for the diagnosis is actually an elderly woman, typically 60s or 70s, who is somewhat malnourished because she's not eating that much for whatever reason, and she's taking Tylenol every day for arthritis or some other kind of chronic pain, and then she becomes confused or worse, delirious, or even worse, comatose. If that person has a high anion-gap metabolic acidosis and the other common culprits of the MUDPILES have been ruled out, think of this diagnosis. Now, one of my favorite mentors in med school when I was doing my internal medicine rotation, Dr. I, he would always say this to us. He would always say, you can't make the diagnosis unless you think. Now, getting back to the patient in this case, this 83-year-old man, the medical team, they had to act swiftly based on their clinical suspicion. They discontinued the acetaminophen and they switched to the antibiotic called cefazolin. To replenish the patient's glutathione stores, they gave something called IV NAC or IV NAC, which is N-acetylcysteine, and NAC is a precursor of glutathione. They also gave sodium bicarbonate to normalize the blood pH, and they did continuous renal replacement therapy, aka dialysis, in order to help correct the patient's metabolic abnormalities. Slowly but surely, the patient began to improve. Within 48 hours, he started to regain consciousness, and after several days in the intensive care unit, he was finally discharged, and at that point, he was awake, he was alert, he was oriented to person, place, and time. A subsequent urinalysis was done to test for those organic acids, and it ended up being positive. It confirmed the diagnosis of pyroglutamic acidosis. The main learning point from this case is the importance of considering rare causes of high anion gaps, particularly in high-risk patient groups or those that fit a certain type of pattern, a certain type of story. Pyroglutamic acidosis should be on the differential diagnosis for patients presenting with unexplained high anion gap metabolic acidosis, especially in those who are chronically taking Tylenol or acetaminophen. So that third P in your MUDPILES mnemonic should be pyroglutamic acidosis. You got propofol, you got propylene glycol, and now you can add pyroglutamic acidosis if you don't have it already. This case also highlights the complex interplay between medications and every person's unique biochemistry. Every medication has the potential for adverse effects or side effects, even something that's generally considered safe like acetaminophen, aka Tylenol.